My name is Kayla Olson. I'm going to be talking about understanding and navigating prolapse. And then questions hopefully will be answered at the end. So just disclosure, some images in the presentation are used with permission and are copyrighted images from Pelvic Guru, LLC. The objectives of the talk tonight will be to define what a prolapse is, talking about epidemiology, risk factors and symptoms, types of prolapse. We'll review some non-surgical management and what PT can do for you, and some surgical management at the end. So what is a prolapse? So pelvic organ prolapse happens when there's a weakness of the pelvic floor and connective tissue attachments to the bony pelvis. It's defined by herniation of the anterior vaginal wall, posterior vaginal wall, uterus, or vaginal apex into the vagina, and descent may occur in one or more structures. Most women feel symptoms of prolapse when the leading edge reaches 0.5 centimeters distal to the hymen or past the hymen remnants. And it's common in a benign condition in women that may affect quality of life, including bowel, bladder, and sexual function. So just to look at prevalence and epidemiology of it, although pelvic organ prolapse can affect women of all ages, it commonly occurs in older women. The prevalence of prolapse increases with age until the peak of 5% in 60 to 69-year-old women. 50% of women who have given birth at least one time will have some degree of organ prolapse. Some degree of prolapse is present in 41 to 50% of women on physical exam, but yet only 3% of patients report symptoms. So it's actually more common and people are asymptomatic. In a study of over 9,000 women, a year or more postpartum, there was evidence of uterine prolapse, asystocele, rectocele, and 65% were grade 2 and 80% were asymptomatic, meaning that they did not have symptoms. And we'll go over what each one of those prolapses actually are. Limited data suggests that prolapse progresses until menopause with low rates of progression and regression thereafter. Women in the US have a 13% lifetime risk of undergoing surgery for prolapse, and the number of women who have pelvic organ prolapse is expected to increase by 46% to 4.9 million by 2050. So what are some risk factors for a prolapse? Essentially, anything that puts increased downward pressure on the abdomen can lead to a prolapse. So common risk factors include pregnancy, labor, and childbirth, which is the most common cause. And that includes a vaginal childbirth. And multiple childbirths will actually increase your risk of prolapse. Giving birth to heavy babies, lacerations, stretching, or tearing during delivery, use of forceps or vacuum-assisted delivery. Then there also can be a family history, genetic, or connective tissue disease that has some risk for a prolapse, including genital prolapse will typically come with a history of joint hypermobility, menopause and hormonal changes or loss of estrogen, increasing age or aging, obesity and being overweight, chronic constipation and straining, respiratory problems with a chronic long-term cough, previous pelvic surgery, including prolapse surgery or hysterectomy, pelvic organ cancers, pelvic floor dysfunction, regular heavy lifting, or exercise overload. Some common symptoms of prolapse include vaginal tissue bulging or the feeling that something is coming out of the vagina, pelvic heaviness or fullness or pressure in the pelvis, pelvic pressure that gets worse with standing/coughing or as the day goes on and is relieved with gravity-reduced positioning, lower back pain or dull ache or pelvic pain, lower abdominal pressure or discomfort. You may have some urinary symptoms, including incontinence, urgency, urinary retention, or bladder pressure on the urethra/the shape, frequent urinary tract infections or chronic UTIs. It can lead to fecal incontinence or fecal leaking or fecal smearing. Bowel emptying problems, including chronic constipation. It can lead to increased gas or flatulence, problem inserting tampons, needing to manually reposition the prolapse or splinting to empty the bladder or bowel, spotting or bleeding from the vagina, and painful intercourse or problems with sexual functioning. So we bring up increased intra-abdominal pressure a lot, and we always want to talk about why it's important. And I know that, what I just said on the last slide too was that anything with increased intra-abdominal pressure down may increase your risk of a prolapse. So why is that important? So poor intra-abdominal pressure system control is of high value. So we always bring up, I really like the analogy of the soda can, right? So if the soda can is closed and you shake the soda can, you're increasing the pressure. What happens is that the pressure increases in all directions, right? So it just expands in all directions, right? So if we think about how we release that pressure, we need to pop the top, right? And then all of the pressure goes out the top and then it explodes. But if we think about our core as a soda can, we can think about our glottis and vocal cords as that pop or the top that you need to pop. Our diaphragm controls the key pressure regulator for our core. We have the transverse abdominis or your internal oblique on the front. We have the pelvic floor as our floor. We have some deep psoas, deep quadratus lumborum, and multifidi on the back. So we want to make sure that we are controlling our pressure system in our core. So we typically want the abdominal pressure to be intended and directed towards the vocal cords for coughing, sneezing, yelling, laughing, but sometimes we're not great at controlling that. And it's shown that stress and strain distributions in the vaginal wall showed that posterior wall was more stable than the anterior wall under high intra-abdominal pressure, which on the next slide we'll talk about it, but that just means that the front wall of the vagina is less stable than the back wall. And when there's insufficient pelvic floor strength or motor control, it does equal a reduction in positive pressure throughout the pelvic opening, which then leads to increased stress incontinence and prolapse. So for prolapse, the current diagnosis, the recommendations characterize the site of the prolapse as the anterior vaginal wall, posterior vaginal wall, or the vaginal apex or apical prolapse. An apical prolapse is sometimes referred to as a uterine or cervical prolapse when these structures are present. After a total hysterectomy, though, prolapse is of the vaginal cuff and it's referred to as the vaginal vault prolapse. An anterior prolapse is 2 to 3 times more common than the posterior or apical prolapse, respectively. And that has to do with what they just found in that previous study, that the posterior wall is just more stable than the anterior. So what are the types of prolapse? So anterior wall or the front wall of the vagina can lead to a cystocele or a urethrocoele or a cystourocele. The posterior wall or the back wall can lead to a rectocele, which is the rectum coming forward, or an enterocele, which is a small bowel coming forward, and an apical or a uterine or a uterus prolapse or a vaginal vault prolapse if the uterus has been removed already. And so these are just pictures of each one of those. So you can see on the left that for the cystocele, the bladder has fallen a little bit. The rectocele, the rectum has come forward and past the anus. For the uterine prolapse, the uterus has started to fall. The enterocele, you can see the small intestine, and the vaginal vault is the kind of just shows the anterior and posterior or the front and back wall of the vaginal canal has fallen forward. So you see a little bit of the rectocele and cystocele coming down. And we'll go through each one of those individually as well. But some of the main factors that contribute to the development of a prolapse include a hereditary component. So cystoceles tend to run in families. Childbirth, so vaginal deliveries can stretch or weaken the supporting structures of the pelvic floor. Age, so supporting structures of the pelvic floor weaken with an increased age. So to go through, a cystocele is that bladder coming forward and coming down. It is known as a bladder prolapse. It occurs when the pelvic floor muscles and ligaments between the bladder and vagina weaken, allowing the bladder to sag into the vagina. Symptoms may be more noticeable at the end of the day or after standing for long periods of time. Common symptoms include a soft bulge of the tissue in the vagina that protrudes through the vaginal opening, pelvic pressure or heaviness, difficulty emptying the bladder with reports of poor or prolonged urinary stream, Positional changes to complete urinary stream, stress or urge incontinence, the need to press one's finger into the vagina to reduce a bulge, we call it splinting, or the need to reposition to empty the bladder, chronic urinary tract infections, painful intercourse, and women with a prolapse may feel a bulge in the vagina, or it's as if they're sitting on a ball. Just going to take a quick sip. So then we have a rectocele. And so it really is just the definition is the rectum is coming forward to the back wall of the vagina. And that occurs when the wall between the woman's rectum and vagina weakens, allowing the rectum to drop forward. Common symptoms include vaginal pressure or discomfort, a soft bulge of tissue in the vagina that protrudes through the vaginal opening, difficulty having a bowel movement, the need to press your fingers on the bulge in your vagina or perineum to help push stool out during a bowel movement, sensation of rectal pressure or fullness, and a feeling that the rectum is not completely emptied after a bowel movement. Additional factors that contribute to the development of a rectocele include chronic constipation or chronic straining during bowel movements. Perineal descent is often present in women with a rectocele as well, especially if there's a history of chronic straining from constipation. Women with a rectocele may also have perineal relaxation, so stretching and relaxation of the vaginal opening, or fecal incontinence. So this is just a couple of pictures of splinting. So splinting can be used for difficult evacuation of a bowel movement. And really what you're doing is you're pushing the perineal body or the vaginal wall, and you're using your thumb or fingers to minimize the stretch or the descent of the tissues and organs. So you're really just trying to push it backwards towards the anus so that the rectum can come and all the stool can come out a little bit smoother versus going past it and then not being able to evacuate completely. And then there's a uterine prolapse. So a uterine prolapse or a pelvic organ prolapse occurs when the pelvic floor muscles and ligaments stretch and weaken again. So the weakening of the support structures allows the uterus to move out of its normal position and drop into the vagina. The uterine prolapse may shorten the length of the vagina or may fall down far enough to protrude through the vaginal opening. Some common symptoms include the sensation of heaviness or pulling in your pelvis, a bulge protruding from your vagina, pain with sexual activity, difficulty inserting tampons, low back pain, and possible blood-stained discharge. Then we have an enterocele. So an enterocele can be present in patients who have a uterus and develop a prolapse, but it is not as common. When this is the case, fatty tissue around the intestines descends into the pelvic cavity and forms a bulge between the cervix and the vagina. Some common symptoms: a feeling of pelvic fullness, pressure, or pain. The discomfort is often worse at the end of the day or with heavy lifting. Low back pain that worsens throughout the day and improves when laying down. A soft bulge of tissue in the vagina that increases in size with standing or with activity and decreases in size when laying down. A vaginal discomfort and painful intercourse. And some additional factors that can contribute to the development include prior hysterectomy. So if the uterus was removed in the past and the prolapse develops, an enterocele can be present. So we look at this in terms of staging. And for us as PTs, staging is very important. So a stage 0, so the description is on the left, the picture is on the right, but on stage 0 is no prolapse. So everything is in its place where it's supposed to be. Stage 1, the criteria for stage 0 are not met, and most distal prolapse is more than 1 centimeter above the level of the hymen. Stage 2 is really when people start to feel it. So most distal prolapse is between 1 centimeter above and 1 centimeter below the hymen. And if you can remember, in terms of when we really feel the symptoms, we usually start to feel it around that half centimeter level. Stage 3 is the most distal prolapse is more than 1 centimeter below the hymen, but no further than 2 centimeters less than the total vaginal length. And stage 4 is a complete vault eversion. typically when we are seeing this in the clinic, and what the research has showed is that PT is very helpful for stage 1, 2, and 3. But a lot of the times between the stages of 3 and 4, usually need surgical treatment. So the ACOG or the AUGS joint statement says that pelvic organ prolapse only should be considered a problem if it is causing prolapse symptoms. So a pressure with or without a bulge, or with sexual dysfunction, or if it is disrupting normal lower urinary tract or bowel function. So if we talk about some non-surgical treatment, for physical therapy, it's used by improving muscle strength and coordination with pelvic floor PT. The resting position of the uterus, bladder, and rectum can be elevated to decrease symptoms, reduce the POP-Q stage, which is those stages that we just went through of the prolapse, and improve quality of life. There's evidence for PT. So the largest study to address pelvic floor PT for prolapse was the pelvic organ prolapse physiotherapy trial, which was a multi-center random controls trial at 23 centers. Women with newly diagnosed symptomatic stage 1, 2, and 3 prolapse were randomized into pelvic floor PT or a prolapse lifestyle advice pamphlet. And the women with pelvic floor PT or completed pelvic floor PT had a significantly greater reduction in prolapse symptom scores at 12 months. In 2016, a meta-analysis for 13 control studies or randomly controlled studies reported that women who had pelvic floor PT for prolapse had a greater improvement in objective prolapse stage, and the number of women who reported prolapse improvement was higher. In 2013, an international consultation of incontinence report concluded that there is level 1 grade A evidence to recommend pelvic floor therapy in the treatment of prolapse. So many of the randomly controlled trials showing improved outcomes with pelvic floor PT had physical therapy regimens with individualized training and vigorous supervision. So what does that mean? So for pelvic floor PT, a lot of the times we are talking about behavioral, conservative, and lifestyle changes. So we kind of think about what is causing the symptoms and how can we help and adjust. The picture on the right shows a great position if we're thinking about standing for prolonged period of time is causing more stress and more increased pressure down onto the pelvic floor and onto our organs. We think about removing that gravity or having gravity assist us to pull everything back in. Some modifiable risk factors that we don't necessarily cover in PT in terms of obesity, but for constipation, we do. And we'll talk about that on the next slide. Control of intra-abdominal pressure. So managing that pressure system that we were talking about with the soda can, right? So we want to avoid intra-abdominal pressure through the strain with voiding. So if we are increasing our strain to go to the bathroom, right, for a bowel movement, then we are pushing down and we're bearing down. So we might not only be pushing down and out stool, right? We might be pushing down on our organs as well. If we also think about moving throughout the day and how much we actually hold our breath or holding our breath with lifting something heavy, we are increasing that intra-abdominal pressure. So we always want to exhale when we think about moving, even if it's just getting out of a chair. We want to exhale or getting out of bed. We always want to exhale when we are doing things that could cause strain. And then we address pelvic floor. We increase the strength, and so we do pelvic muscle exercises. But we also address the pelvic floor tension, or sometimes we have tightness in our pelvic floor, and we address that if it's present. So when we talk about managing constipation, the picture on the right is very important. So we always think about why are we straining so much to have a bowel movement? And so if we're sitting in a 90-90 position, there's actually a muscle in your pelvic floor that will choke or constrict the rectum and the anal rectal canal when we are just sitting in a 90-90 or standing position. if we get our feet up onto something, so we a lot of the times will recommend what is called the squatty potty, or even just a stool, it gets us into better position to be able to go to the bathroom. So it allows us to have decreased straining when we're going. Other than that, we want to increase the fiber. We want to increase fluid or water. We want to increase your movement. So you allow for more food to move through your GI system faster, which all of that improves your stool consistency. When you have an urge to go to the bathroom, you want to go. You want to give yourself time in the morning or after a meal to have a bowel movement. So we actually have a gastric reflex that occurs approximately 30 minutes after we eat a meal or drink a hot beverage. And it's the body's automatic mechanism to move stool. And if we do have to strain, we really want to exhale as we bear down. So if PT is kind of, if we're not really meeting the goals that we want to meet, or we're seeing some plateau, or say that the degree of the prolapse is just a little bit more than PT might be able to help with, a pessary is also a non-surgical treatment. And so it's a device that is non-surgically inserted into the vagina to reduce the prolapse, provide support, and relieve pressure on the bladder and bowel. It generally considers a low risk option and a good alternative for women who wish to maintain fertility. And the follow-up is every 3 to 4 months, if the patient cannot replace it on their own, or annually if they can. So a lot of the times we have some patients that will use these devices if they, want to go play tennis, or they want to go run, or they want to go lift if they are younger and able to put the pessary in themselves. And I've had some patients too that are a little bit older that have the same goal in trying to just be more active, and sometimes it's even going for a walk. And then there's others that it's really hard to be able to insert and figure out and manage these pessaries on their own. So they'll go back to their OBGYN every 3 months to have them manage it. But essentially what it is doing is it is lifting up the organs. And a lot of studies are now showing that the combo of a pessary and pelvic floor PT is actually one of the best options. So if the conservative treatment doesn't work, there's also surgery for failed or declined non-surgical treatment. And this is just a little chart of showing all of the different types of surgeries that may be offered. So I'm not going to go into a ton of detail on them, but they're really just to be able to correct upper vaginal prolapse, or lower or anterior or posterior, so that front wall or that back wall. And they're really just trying to address the different types of prolapse that you may encounter. And then this was just a little thing. So a lot of the times we are hearing now about the mesh as a surgical treatment. So April 2019, the FDA ordered manufacturers of synthetic mesh for prolapse to discontinue sale and distribution in the US. And that only applies to transvaginal mesh and not the transabdominal for prolapse or stress incontinence. In 2022, the Coloplast 522 study was completed, and it was a 36-month follow-up data that was reviewed by the FDA. And it showed that that transvaginal prolapse mesh had similar effectiveness and safety outcomes to the native tissue repair at 36 months. But they continue to believe that the devices of the type for transvaginal prolapse mesh repair present potential additional risks, including mesh exposure and erosion. So the FDA maintains that these devices do not have a favorable benefit risk profile and was discontinued. And so some of the most common complications reported for the mesh and repair included mesh erosion through the vagina, pain, infection, scar tissue, bleeding, incontinence, neuromuscular problems, fistula, organ preparation, recurrent prolapse, abnormal vaginal discharge, bowel obstruction, or pain during sexual intercourse.